I'm Beyda. I'm one of the fourth year EMIMs. I wanted to first take a minute to thank Drs. Taw, Drs. Vicenti, and Carmelli for the feedback for my talk. I want to start out with a case, just to frame the context of the discussion. He's a 55-year-old male who's presenting with generalized weakness. He's got a history of chronic alcohol abuse, multiple admissions for dehydration, vomiting, gastritis, pancreatitis, weakness, alcohol withdrawal, seizures, intoxication, inability to ambulate. Does this sound familiar to you? On exam, vitals, blood pressure's a little bit on the low side, 90/60, heart rate's 95, temperature's okay, respiration's okay, finger sticks about 75 milligrams per deciliter. General appearance, overall, not inspiring confidence. Looks a little bit dry, dehydrated, malnourished, cachectic, lean, minimal adipose tissue, frail. So probably what we'll end up doing with this patient is, a little of this and a little of that. We'll probably drop an IV, spike a bag of fluids with some dextrose, maybe some potassium, maybe some mag, and maybe some thiamine, and obviously we'll send off some labs. And our labs will come back and they'll be abnormal. There'll be, in this particular case, a macrocytic anemia, maybe some thrombocytopenia. There's some low total protein, some low albumin. That tells me the patient's overall pretty malnourished. The AST and the ALT are a little bit bumped. That goes along with the history of ETOH. The ketones are positive. There's a little bit of a gap. Maybe it's starvation ketosis or alcoholic ketoacidosis. And there's some electrolyte derangements. So that's our context. Does this sound like a basic routine Pod A patient to you? What I wanted to focus on, though, for today's talk was this right here, the low phos. Because in my view, this is sometimes the forgotten electrolyte. So, my objectives are, you see, you forgot about it. To define hypophosphatemia, what it is, talk about its clinical manifestations, so like why do we care, why is it relevant to us in the ER, how patients become hypophosphatemic in the first place so we can identify patients at risk. That way we know when to send the blood, when to look for it, when it's potentially abnormal, and then when and how to address it in the ER. So, what is hypophosphatemia? It's one of those arbitrary cutoffs. There's a couple of different ranges, but for our intents and purposes, let's just pick less than 2.5 milligrams per deciliter. Sometimes it's less than 2.5 to 3. But when should you really be concerned? It's when it's less than a milligram per deciliter. So then we can say there's mild, moderate, and severe. Mild being 2 to 2.5, moderate being 1 to 2, and severe being less than 1. Okay, that's what it is. How often does this happen? Is this rare? Am I wasting your time? Or is this common? 5% of hospitalized patients. But our really sick patients, up to 20 to 25%. So this is the patients that we're admitting to the ICU, our septic patients, our chronic malnourished patients, our alcoholic patients. So it's not uncommon, and it's just common enough that it's worthy of looking for. Why is it important? What does it do to the patient? Well, when there's low phosphate, there's low ATP. And when there's low ATP, muscle function not good. And when muscle function not good, respiratory muscle function even worse. So it leads to respiratory muscle dysfunction. What about oxygen delivery? When phosphate's low, 2,3-DPG is low. And when 2,3-DPG is low, oxygen delivery to the tissues is also low. The same is true for cardiac muscle. So if skeletal muscle has dysfunction, so does the cardiac muscle. And you can get decreased cardiac contractility and even some arrhythmias. The same is true for phospholipid membranes. Phosphate has a role in phospholipid bilayers, and so you can get acute hemolysis and even platelet dysfunction. You can also get acute rhabdomyolysis with all the consequences of this. And you could also get seizures. So clearly it does a lot to the body and it affects multiple organ systems. So how does it happen? How do we get there in the first place? Well, patients could either have no access to food, in which case they're just not taking it in and they're becoming malnourished over time, or they're taking it in and they're taking a ton of antacids, so there's decreased absorption, or they have a malabsorption syndrome and they're just not absorbing even though they're taking in enough, or their vitamin D levels are low and they're not taking it enough, or they have some sort of diarrheal illness and they're losing it in the stool. They could also lose it in the kidneys, so they're peeing out too much, we're over-diuresing patients, or their parathyroid hormone levels are too high, and so they're losing a lot of it in the kidneys. But what's most relevant to us in the ER is this mechanism right here in the middle, the intracellular shift. So here's another slide talking about all three of these mechanisms. Decreased intake, renal losses, some overlap, but really what's most relevant to us is this pathophysiology right here, this refeeding pathophysiology. This is what happens with our starving, malnourished, malabsorption, chronic alcoholic patients, and some of our patients that we even resuscitate from DKA and HHS. So just a word on refeeding pathophysiology. What's going on here? So our patient is starving, malnourished, doesn't have access to food, or has some sort of malabsorption syndrome, or is replacing their daily calories without carbs, but rather with alcohol. And so essentially their hormonal milieu is replaced from high insulin to high glucagon, high stress hormones, and they enter into a catabolic state, breaking down muscle, breaking down fat, mobilizing fatty acids, and producing ketones for fuel instead of carbs for the brain and the heart. This patient enters into the ER, we provide them with dextrose-containing fluids, and all of a sudden everything gets acutely reversed, only too quick for the body to handle. So now everything is reversed and glucagon goes down, insulin goes up, and whatever's present in the serum shifts into the cells, and patients can become profoundly hypokalemic, hypomagnesiemic, and hypophosphatemic with all of the clinical consequences that we just reviewed. So who's at risk? Now that we know how it happens, who are the patients that we should be concerned about? Obviously, our chronic alcoholics, malnourished, starving patients because of either chronic illness, eating disorders, chronic infectious illness, chronic malignancy. Our DKA patients that we resuscitate, or our hyperglycemic crisis patients, can become hypophosphatemic. Chronic GI malabsorption syndromes like inflammatory bowel disease, bacterial overgrowth, celiac, short gut syndrome. Hungry bone syndrome. So a patient comes in after parathyroidectomy, wigging out, tremors, irritable, their calcium is low. We've just removed the parathyroid hormone, so there's no more bone resorption, and the bone is essentially taking up phosphate and calcium. Vitamin D deficiency and high parathyroid levels. So what to do? What do you do when you see a patient like this in the ER? You know what it is when they're hypophosphatemic. You know how bad it is. You know how common it is. You know who's at risk. You've assessed your patient. You sent off a level, and it's really low. What do you do? Well, there's two routes to replete phosphate. You can either do PO, that's your Nutrifos tablets or packets, and this is really more relevant to the inpatient kind of medical ward, not on the acute setting. Or you can replete through the IV route. And there's two main IV formulations. There's the potassium phosphate, and then there's the sodium phosphate. And how to pick between the two really depends on the patient's potassium levels. So if the potassium is high, pick the sodium phosphate. If the potassium is normal, you have the choice between the two. If the potassium is normal and the sodium is too high, then maybe pick the potassium phosphate so you don't precipitate either a hypernatremia or a hyperkalemia. Are there any risks of repleting phosphate? Well, the answer is yes. The risks are hypocalcemia with arrhythmias and irritability and neuromuscular irritability and seizures, and phosphates forming complexes with calcium and precipitating out in the tissues, and also phosphate nephropathy. Now, this is less relevant when we're talking about the refeeding syndrome pathophysiology when you're coming to replete phosphate, and it's more relevant to those chronic hypophosphatemic patients, the ones that are losing it in the urine, the ones that are losing it in the stool, and the ones that just are not absorbing it. So it's less of a concern to us. But if you do have a patient with renal dysfunction, take whatever dose that you've calculated and just half it. Okay, so back to our case. So we've got our 55-year-old gentleman who's in the ER. He's malnourished, he's here for dehydration, he's weak, he looks ill, he looks dehydrated. Now, we'll drop an IV, we'll send off our blood, we'll look for our expected abnormalities, we'll spike our bag of fluids, we'll give him some potassium, we'll give him some mag, we'll give him some thiamine, and now we'll also address, we'll have a plan for the phosphate as well. So in summary, Hypophosphatemia is important. It has a lot of clinical manifestations. Certain populations are at higher risk for it. Management is based on rapid identification and appropriate phosphate repletion. Finally, don't forget about the phosphate. Thank you. To my right. Dr. G. Dr. G.
That's very good. There are a couple of points. One is, it became, like you mentioned, DKA, you will see hypophosphatemia. Especially a lot of these patients have gotten, malnourished, type 1s, and they come in like that. And for a while there were studies to show, and maybe we should, instead of giving potassium chloride, we should give potassium phosphate. Give half our potassium in this phosphate to make up for when they're getting the insulin. And most of the studies show that you didn't need to do that. That you could just give it as potassium chloride as long as you could get them eating soon. That once you got them to the point where they didn't vomit and the point where they weren't altered, that if they ate and you get food in, that's a great source of mold phosphate, a good diet. And so now most experts don't give K-phos for DKA if the patient can start eating within a day or so.
Yeah, that's exactly true. It's when the patient can't tolerate PO. So for example, sometimes if it's the really severe DKA and they're becoming really hypophosphatemic, essentially DKA, it's almost like they're a starvation state. They're not able to take up the carbs and glucose because essentially they're insulin deficient. And you've provided them with that insulin, that substrate, and now they can take everything in. But there's that small percentage of DKA patients, they're not recovering as fast, they end up going to the ICU and they're really sick. They are potentially at risk for this. And there are case reports of patients developing the rhabdo, the respiratory failure. It's tough to say if it's because of the DKA, other metabolic abnormalities, or because it's made worse by the hypophosphatemia. Yeah.
Insulin infusion lowers phosphate.
Yes.
The glucose goes into the cell, and the very first thing that happens is it's attached to phosphate. It's the hexokinase, and it just sequesters all the phosphate inside the cell. So any insulin infusion is going to lower phosphate pretty dramatically.
The other thing I just want to mention, you mentioned this too. When you do give IV phosphorus, again, be very careful about the calcium. Even when, in the old days, before we had some of the newer drugs that we now use to treat severe hyperphosphatemia, before we even had calcitonin even, and especially before we had the bone drugs, we used to use phosphate, and I would see those calciums plummet to the point even where they'd start hypercalcemic and they get hypocalcemic real quickly and start to get tetany and things like that. So you have to be very, very careful, especially what you might see. What we did see in those days is you'll start to see calcification in the tissues. The calcium gets driven out of the blood. And you'd even see on x-rays people getting calcified. So be very careful when you give IV phos. Keep your eye on the calcium.
I know everybody and their mother has their own opinion on electrolyte repletion.
Yeah.
I usually use that online surgical quick care one.
Yeah, so do I. I just remember 15, 21, and 30 for mild, moderate, severe.
Does it pause?
Yep.
Okay.
Is that what you're going to ask? Or?
I just
What were
really
you
guess, like Ari will come out and say like double, triple it, whatever it is, whatever we calculate, over aggressive. Do you have any thoughts on like just all of it in general, like how you replete?
Yeah, that's why I didn't talk about the dosing, because the dosing is exactly like you said. It's one of these annoying things where, sometimes it's measured, it's abnormal, and now what do you do about it? That's why I called it the ignored or forgotten electrolyte, because sometimes it's measured and it's actually low, and then so I'm guilty of kind of looking the other way. I'll do the potassium, I'll do the mag because I feel more comfortable with it. But it is something that has associated consequences. So now you make the decision, you do want to replete it. So what do you do? So I like that resource. So what he's talking about is that surgical critical care. Every time you rotate through the ICU, it's the phosphorus repletion. That's a popular one. And the numbers that I remember are 15, 21, and 30 millimoles of either the sodium phos or the K-phos, and you run it over 4 to 6 hours. And you run it with the expectation that you're just going to measure it in a few hours to see if you're going too high, going too low, or like Dr. G is saying, with the risks of the phos repletion, are you developing any of the complications? So you just have to monitor the patient. And presumably the patient is really sick if you're giving the IV phosphate product, so they're probably in a monitored setting or in the ICU. The other resources there are a couple of guidelines, but there's up to date, and they calculate it on a millimole per kilogram. It's too much math. I just like the 15, 21, and 30. And then I just reassess.
Could you give some recommendations for our viewers regarding routine phosphate levels?
Routine.
Because I noticed a lot of times
Like sending
people
them out.
order phosphate on whatever.
So that's why I wanted to talk about, like, patients are at risk for it. I mean, it's like any blood test that you're gonna get. You get the blood test because you expect to see, so first of all, knowing what variables are present on the blood test. So what do we always order in the ER? We order a CBC, but we look at the H&H, the white count, the platelets, the MCV, and sometimes we'll look at the diff. But there's a lot of other things, and we get skewed in a whole bunch of different directions. You have to know what's there and how to interpret it. Some of those variables, it's just not going to be relevant, we're not going to care. But a lot of those things, it's like opening up a Pandora's box. It's now introduced into the differential for the patient. The same is true with a comprehensive. You get a comprehensive, there's a sodium, you have to know what's there. Sodium, potassium, chloride, bicarb, and the difference between a BMP and an LFT, what are these variables, and how to interpret them. When you order it and there's an abnormality, it's either an acute abnormality, it's a chronic abnormality, or it's an acute on chronic abnormality. And our business is acute care medicine, emergency medicine. If there's an acute abnormality on the lab, we have to address it because it potentially explains why our patient is sick. So the same is true for the phosphate. So knowing which patients are expected to have a low phos, or if they have a clinical presentation that could be potentially explained by low phos, when you get the phos and it's low and you expected it to be low, you have to address it. It may be just saying, we'll give them something PO, we'll sign out to the admitting team, or if they're really sick, giving them some IV. Yes. All right, thank you guys. Thank you very much.
Thank you, Dr. Beyda.